Namaste बिटिया हमेशा खुश रहो बिटिया A very good morning to you all. Myself, JV and Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine in Faculty of Homeopathy Science at Jyoti VIDYAPEETH Women's University, Jaipur. In this series of lectures, we are discussing about the various disorders related to the alimentary tract. In this lecture, we are going to discuss about inflammatory bowel disease. What is inflammatory bowel disease? What are the clinical features? How to investigate and the management of inflammatory bowel disease. So, inflammatory bowel disease, as the name suggests, it is an immune-mediated chronic inflammatory disorder of unknown etiology that is involving the gastrointestinal tract. There are two types of inflammatory bowel disease. Number one, we have ulcerative colitis, and second one is the Crohn's disease. So, IBD is an immune-mediated chronic inflammatory disorder of unknown etiology involving the GI tract. There are two major types. We have Crohn's disease and ulcerative colitis. First of all, we will be discussing about ulcerative colitis. Ulcerative colitis, a mucosal disease that usually involves the rectum and extends proximally to involve the other part of the colon. Ulcerative colitis spreads proximally in continuity without the areas of uninvolved mucosa. The incidence is of 10 to 20 per 1 lakh population. The age of onset is 2nd to 4th decades and 7th to 9th decade. The female is to male ratio is 0.5 to 1.5. That is, it is 3 times more common in males as compared to females. Antibiotic use in the first year of life increases 3 times the risk of development of inflammatory bowel disease. Smoking is ulcerative colitis. Smoking is an important risk factor of ulcerative colitis. With infectious gastroenteritis and with pathogens Salmonella, Shigella, etc., increases the IBD risk by 2 to 3 folds. Diets high in animal protein, sugars, sweet oils, and dietary fat have increased the risk of IBD. IBD is basically a familial disease. Now, the pathophysiology of ulcerative colitis. Inflammatory bowel disease develops because of the abnormal host response to an environmental trigger in genetically susceptible individual. It causes inflammation of the intestine and releases inflammatory mediators such as tumor necrosis factor, interleukin 12 and 23, which causes tissue damage. The intestinal wall is infiltrated with acute or chronic inflammatory cells. The difference is in the distribution of the disease and the histological features. Now let's discuss about the macroscopic pathology of inflammatory bowel disease. Ulcerative colitis involves the rectum and extends proximally to involve all the parts of the colon. The proximal spread occurs in continuity without the areas of uninvolved mucosa. The inflammation extends 2 to 3 cm into the terminal ileum, that is known as backwash ileitis. With a mild inflammation, the mucosa is erythematous and has fine granular surfaces that resembles a sandpaper. In severe disease, the mucosa is hemorrhagic, edematous, and ulcerated. Mild inflammation. In case of mild inflammation, the mucosa is erythematous and has fine granular surface that resembles sandpaper. In more severe disease, the mucosa is hemorrhagic and edematous and ulcerated. The inflammatory polyps, pseudopolyps, are present as a result of epithelial regeneration. The fulminant disease can develop toxic colitis or megacolon, where the bowel wall thins and the mucosa is very ulcerated. This may lead to perforation. In the microscopic appearance, ulcerative colitis is limited to the mucosa and superficial mucosa, with deep layers unaffected except the fulminant disease. Mucosal vascular congestion with edema and focal hemorrhage. The inflammatory cell infiltrate of neutrophils, lymphocytes, plasma cells, and macrophages are present. The neutrophils invades the epithelium, usually in the crypts, giving rise to cryptitis and ultimately crypt abscess. There are features of villus atrophy and crypt regeneration. The clinical features of ulcerative colitis. The symptoms are present acutely and they have been present for weeks to months. The major symptoms are diarrhea, rectal bleeding, tenesmus, passage of mucus, crampy abdominal pain. Occasionally, the symptoms are so mild that the patient does not seek medical attention. There is tenesmus or urgency with a feeling of incomplete evacuation, but rarely abdominal pain. In severe cases, patients pass out a liquid stool containing blood, pus, and fecal matter. Diarrhea is nocturnal and postprandial. The other symptoms include anorexia, nausea, vomiting, fever, and weight loss. Now the laboratory finding, endoscopy, and radiographic features. In case of ulcerative colitis, there is rise in C-reactive protein, platelet count, erythrocyte sedimentation rate. There is decrease in hemoglobin. Leukocytosis may be present. The diagnosis is based on the patient's history, clinical symptoms, negative stool examination for bacteria, and histology for rectal or colonic biopsy specimen. The sigmoidoscopy is used to assess the disease activity before the treatment. Colonoscopy to assess the disease and extent of the activity. In case of mild disease, this is characterized by erythema, decreased vascular pattern, and mild friability. In moderate disease is characterized by marked erythema, absence of vascular pattern, friability, and erosions. The severe disease is characterized by spontaneous bleeding and ulceration. Radiography single contrast barium enema is a fine mucosal granularity. With the increasing severity, the mucosa becomes thickened and superficial ulcers are seen. Collar button ulcers are seen in case of ulcerative colitis, which indicates that the ulceration has penetrated the mucosa. Loss of haustration can occur with long-standing disease. The formation of pseudopolyps. Computed tomography or magnetic resonance imaging is not at all useful. The complication: 15% of the patients with ulcerative colitis presents with catastrophic illness. Massive hemorrhage occurs with a severity of attacks of disease in 1% patients. Toxic megacolon, a transverse or right colon with a diameter of greater than 6 cm, with a loss of haustration in patients with severe attack of ulcerative colitis. It occurs in around 5% of the attacks that can be triggered by electrolyte abnormalities and narcotics. Perforation is the most common, dangerous of the local complication, and stricture occurs in 5 to 10% patients. Now we come to the Crohn's disease, the changes that we are going to see, the macroscopic changes in the Crohn's disease. Crohn's disease can affect any part of the GI tract from the mouth to anus. 30 to 40% of the patients have small bowel disease alone, with 40 to 45% have disease involving both small and large intestines, and 15 to 25% have colitis alone. The terminal ileum is involved in 90% of the cases, with rectum is often spared. It is the segmental with skip areas in midst of the diseased intestine. Perirectal fistulas, fissures, abscess, and anal stenosis are present in 1/3 of the patient. It is a transmural process. In the mild disease, aphthous or small superficial ulcerations are present. More active disease, stellate ulcers, fuse longitudinally and transversely. There is cobblestone appearance that is characteristic. Active stage is characterized by focal inflammation and formation of fistulous tract, which resolve by fibrosis and stricturing of the bowel. The bowel wall thickens and becomes narrowed and fibrotic, leading to the chronic recurrent bowel obstruction. Serosal mesenteric inflammation promotes adhesion and fistula formation. Now the microscopic appearance of Crohn's disease. There is aphthoid, ulcerations, and focal crypt abscess with loose aggregations of macrophages, which form non-caseating granulomas. The granulomas are pathognomic feature of Crohn's disease. These can be seen in the lymph nodes, mesentery, peritoneum, liver, and pancreas. The histological features include submucosal and subserosal lymphoid aggregates away from the areas of ulceration, gross and microscopic skip areas, and transmural inflammation. The clinical feature, the presentation of Crohn's disease. The Crohn's disease present as acute or chronic bowel inflammation. There are two patterns of disease that is seen in case of Crohn's disease. One is fibrostenotic obstruction, and the second one is penetrating fistulas. The major symptoms in case of Crohn's disease is abdominal pain, diarrhea, and weight loss. It causes subacute and even acute intestinal obstruction. The pain is often associated with diarrhea, and diarrhea is watery and does not contain blood or mucus. Patients lose weight because they avoid food since eating provokes pain. The weight loss is also due to malabsorption and um, presents with the features of fat, protein, and vitamin deficiencies. A few have isolated perianal disease, vomiting from jejunal strictures, and severe oral ulcerations. Rectal sparing and presence of perianal disease are features of diagnosis of the Crohn's disease. Perianal tag, fissures, and fistulas are found in at least 50% of the patients. There are various sites of disease that is influencing the clinical manifestation, which includes ileocolitis, jejunoileitis, colitis, perianal disease, and gastroduodenal disease. Now, lab finding, endoscopy, and radiographic features of Crohn's disease. In Crohn's disease, there will be elevated ESR and CRP. There will be hypoalbuminemia, anemia, and leukocytosis. There will be endoscopic features that includes rectal sparing, aphthous ulceration, fistulas, and skip lesions. The colonoscopy allows examination and biopsy of mass lesions and strictures and biopsy of the terminal ileum. Wireless capsule endoscopy allows direct visualization of the entire small bowel mucosa. Early radiographic findings include cobblestoning from the longitudinal and transverse ulceration, most frequently involving the small bowel. The earliest macroscopic finding of Crohn's disease are aphthous ulcers. The disease progresses, the aphthous ulcers becomes enlarged, deeper, and occasionally connected to one another, forming longitudinal, stellate, serpiginous, and linear ulcers. The radiographic string sign represents long areas of circumferential inflammation and fibrosis, resulting in long segmental and luminal narrowing. Both CT and MRI of the small bowel can be performed. The complications. Crohn's disease is a transmural process. Serosal adhesions develop. The perforations occurs in around 1 to 2% patients. Intestinal obstruction can be seen. Massive hemorrhage, malabsorption, and severe perianal disease can be seen. Apart from the manifestations of the gastrointestinal tract, Crohn's disease also affects the extraintestinal manifestation. In the joints, it has peripheral arthritis, ankylosing spondylitis. In the skin, there is erythema nodosum, aphthous ulcers, pyoderma gangrenosum, and cutaneous Crohn's disease. In the eye, there is conjunctivitis, episcleritis, iritis, and uveitis. In the liver, there is fatty liver, cholangiocarcinoma, chronic hepatitis. Other features include autoimmune hemolytic anemia, phlebitis, pulmonary embolism, kidney stone, and metabolic bone disease. The management includes treating the acute attacks of inflammatory bowel disease, prevents the relapses, and detect carcinoma in the early stage, and select patient according to the surgery. In the treatment protocol, we have supportive treatment that includes antidiarrheal agents like loperamide, IV hydration, and blood transfusion. There is parenteral nutrition, sulfasalazine and aminosalicylate can be given. Glucocorticoids, immunosuppressive agent like azithromycin and metronidazole. The surgery is done when indicated. In ulcerative colitis, surgery involves the removal of entire colon and rectum. In Crohn's disease, surgery of fistulas, abscess, and perianal disease. Surgery is not curative in Crohn's disease, and the disease recurrence is a rule. So this was all about inflammatory bowel disease, and we will be starting with the next topic, irritable bowel syndrome, in the next lecture. I hope you must have understood the session properly. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. We will be meeting in the next lecture tomorrow with a new topic. Thank you very much. Have a good day.